All right, I'm going to be talking about IMRT breast. It's going to be a comparison of VMAT, static IMRT, and 3D. As we all know, conventionally, breast is treated with 3D tangents. There's a time period where people were investigating static IMRT beams using 2 to 11 beams. But now that VMAT is very common, when you're talking about IMRT breast, it's generally VMAT. So just investigating some of the ways that people were doing static IMRT breast. There's a paper out of British Columbia where they investigated a bunch of patients using 11 static fields, where they planned 30 different left-sided breast patients. And they planned this with traditional tangents and with static IMRT. And they calculated the homogeneity index, the conformity index, V30 of the heart, V20 of the left lung, the V5 of the right lung, and V5 of the right breast. The way that they conform the homogeneity index is a bit different than everywhere else I saw. So I'm going to mention that they are doing the fraction of planned treatment volume. So they dose between 95 and 105% of the prescribed dose. So obviously a perfect value would be 1. So when they looked at static IMRT, they noticed that the homogeneity index was much better. Conformity index was much better. The V30 of the heart and the V20 of the left lung were also both better. As a trade-off, though, the V5 of the right lung, so that low dose spillage, is significantly worse for the right breast and right lung. So this is kind of the intuitive result of you're going to get much better target conformality and probably a little more even dose distribution, but you're going to get much more low dose elsewhere. So there's a study in 2016 out of China that compared all 3 techniques. They basically took a bunch of patients and they designed all 3 plans on the same patient with the same target, OARs, etc. They came to remarkably similar conclusions of you get better conformality and less high dose spill outside of the target. But with IMRT and VMAT, they get more uniform dose, better conformality, but much worse low dose spillage into surrounding tissues. And here's just a comparison of their data. You can see the 3 plans that they had here. Obviously, the 3D tangents, you get this entire area where your blocks are basically giving prescription dose to a portion of the lung, whereas the IMRT and VMAT are able to spare that area at the expense of putting much more low dose outside. You can kind of see in this DVH here that VMAT and IMRT have significantly higher low dose in healthy tissue. So when looking at this, I also found a paper where they're talking about secondary cancer risk increase for VMAT. Since we're giving so much extra tissue low dose, is this a worthwhile trade-off if we're going to end up causing secondary cancers 20 years down the line for a young patient? This may be a terrible course of action. So the way they did this is they used organ equivalent doses, which is a risk estimate method, or is a metric used to calculate the EAR, the excess absolute risk. This is going to tell you the number of cases per 10,000 people per year per gray at age of 70 years after exposure of 30 years. So this is basically looking at 30 years down the line, how many people per 10,000 are going to get a secondary cancer from this treatment. So when looking at this, so T-IMRT is tangential IMRT, so 2 static beams. M is multi-IMRT, so this is using more than 2 beams. So some of the IMRT beams may be exiting through the patient and not necessarily just as a tangent beam would. And then VMAT is the full arc. With quite large error bars, they attributed to the sheer difference in patient anatomy, the size difference in the target. Some of these were 4-field, some were not, or what would be considered a typical 4-field treatment. But when they looked at the numbers, they decided that the secondary risk is negligible for tangential IMRT, saying that there's really no evidence to say that there is any increase in secondary cancer rates. But for multi-IMRT and VMAT, the risk is about 34% higher to develop a secondary cancer. This sounds quite significant, but they do say that the secondary breast cancer induction rate is actually quite low. It's only 7.5 per 10,000 people. With 34% increase, you're really only looking at giving an extra 2.5 people out of 10,000 secondary cancer risk. And then when you weigh this against the fact that you're probably getting significant lung and cardiac dose gain or dose avoidance, that this is a very acceptable trade-off for patients that need this technique.
Are we really though? Are we really benefiting the? So far you've only talked about secondary malignancies, right?
Yeah.
But the other main concern we have regarding BMAT is the dose to the heart, the low dose to the heart. So was this done before we started worrying about the LAD in the
This
heart?
is 2016, so probably around that time period. They didn't put any hard numbers up, but they said you're probably going to gain some benefit if you're choosing to do BMAT over. That'd be an interesting thing to look at.
Because the cardiac gains that we get from BMAT are actually like maximum dose gains.
Yeah. I guess you could push it out of the LAD, but
Yeah,
you're
that's
definitely
true.
going to get
That's true.
more low dose in general, higher mean.
But that's not necessarily linked to, I don't know if that's linked to increased cardiac toxicity, whereas we know that high dose to the LAD absolutely is. Okay, so maybe this was taken into account.
So yeah, so their conclusion was, sure, it increases secondary cancer induction rate, but it's generally an acceptable trade-off. So just as an introduction, I originally came about this talk because I was looking at different ways to plan BMAT breast. The way that we traditionally do it here is the virtual bolus, but I was investigating the robust optimization that RayStation allows. None of the other treatment planning systems or major ones allow you to do this. So I was just investigating it. But the first method is the virtual or fake bolus that we all know, where you create that bolus structure around the breast to optimize against. And this way you're ensuring that flash is going to be delivered with the arc. And then you have to recalculate your beams with the bolus removed because the patient isn't going to be treated with bolus on. The second way is the robust optimization, which is the way I was investigating. And what you do here is, instead of creating a fake bolus, you're just taking the outer 1 cm of your PTD and you're setting a robust optimization criteria on that, saying that this structure may move up to 1 cm in the lateral and anterior direction due to like patient breathing or swelling. And in this way, the optimizer is going to add that flash as well, but you don't need to deal with adding fake bolus, removing it from your beams, recalculating, and just having all that confusion. So one paper I found actually had already done this and looked at this. They had looked at the virtual bolus technique, the robust optimization, and then by manually adding flash to every single control point in their arcs. And here are some dose distributions of 3 techniques. If you look at the DBH, which is really the more meaningful part here, you can see that this MF is the manual flash, the EXPTB is the virtual bolus, and then the RO is the robust optimization. You can see that the manual flash actually looks like it has the best curve. These are all normalized to 95% prescription, or 95% receiving prescription dose. And then what they did is they perturbed the dose and said that the patient had shifted this much during treatment. And then they reevaluated.
I'm sorry. So that's
And then they reevaluated. And you can see the plan where they manually added flash. Actually did an exceptionally poor job of meeting any kind of prescription coverage or giving adequate coverage at all after the patient had added swollen or was set up slightly incorrectly. Whereas the robust optimization and the virtual bolus technique are both fairly satisfied. So another study looked at this and took it a bit differently. Instead of forward planning all these, just planning based on robustness, or just saying that it's going to shift this much, they had actually waited until patients were done with treatment. And then they had taken all the cone beam CTs of the patient and combined them onto a single CT and basically took the furthest extent that the breast ever was, and then did a robust plan based on that. So instead of just arbitrarily saying 1 or 2 cm of shift, they actually saw the number that they observed for a patient during treatment, where they then developed 3 plans on that. One where they didn't push for flash at all, one where they were doing the virtual bolus, and one where they were doing the robust optimization. So this first picture here on the left is the robust optimization. You can see it's giving fairly adequate flash. The second one here is when they did not optimize for flash at all. They just told it to hit the cover, hit the target, and optimize that. And then this third one is using the fake bolus technique. They said that all these plans were able to meet the coverage and OAR constraints, but they said that their end conclusion was that the robust plans were both clinically acceptable and better than the other 2 techniques. So I went up to try this. I actually tried this before I found those prior 2 publications, and I documented how to do it. So we have this red region, which is our target. Did some algebra to get the outer 1 cm of the target, and then added a robust optimization function, where all you do is basically check this box down here to call it robust, which then enables your robust settings in the optimizer. After you open that up, you can pick your uncertainty. This was a right-sided breast patient, so I have 2 cm uncertainty on the right side and 2 cm anteriorly. So it's going to take care of any swelling, or if they're breathing in slightly more for DIBH.
That's more than they did in the paper, right?
It is, yes.
Yeah.
So the way I did this is I did the fake bolus technique and this prior robust technique, and I basically just set them up with the same exact criteria of 12 initial iterations and then 80 iterations after that, and just hit continue 5 times in a row with, besides for the unique optimization functions, such as doing the robust one here or setting the min DBH on the fake bolus. I just didn't change anything, didn't push on hot or cold spots, and just hit continue. First thing that I immediately noticed is the time to take for 80 iterations to complete was significantly different. The robust optimization took about 5 times as long, which I mean kind of makes sense because you have to basically re-optimize at all the different possible positions that the PTV is going to be in. All these were scaled with the breast contour having a 3 mm trim from the external. So that makes them a little toastier in general. And then they are normalized to 95% of the PTV at prescription. So what I saw was the robust method actually gave a much better plan, significantly less 105 than the fake bolus method, and almost no 110. So here we have a side-by-side comparison with the robust on top and the fake bolus on the bottom. Some clinical goals of the prescription, 105, 110, and 95% coverage. And basically the robust was better in every way. But of course, this doesn't really show how adequate the flash was. At that point, I perturbed the dose and reevaluated all these metrics. Just upon visual inspection, it looked like they're both giving decent flash. Here's the robust and here's the virtual bolus, and you can see that it is doing what we intend for it to do. But yes, I perturbed the dose, and you can see that these different perturbations I did, which are signified up here in the legend, and then the percent receiving this isodose line. So the amount receiving 95% coverage with no shifts is almost 100. And then you can see that they're basically identical at every single possible shift. When we look at the 100% isodose line, you can see that the fake bolus is actually slightly better in every shift. The 105% isodose line, you can see that the fake bolus method is actually keeping the plan significantly hotter than the robust optimization.
Can you just go back to us? Why is position 1 always worse than position 2, despite the fact that position 1 is half the magnitude?
I would bet you more than anything so I switched these to make it upward trend, and I forgot to update the legend.
Okay, I was gonna say,
Excellent catch, yes.
the larger the shift,
Yeah,
the worse it should be.
yeah, I forgot to update the legend after I reordered them.
Sorry, YouTube.
So yes, also the 105 and the 110, the fake bolus is just giving a hotter plan. The part that this really optimizes against though is that 1 cm outer ring. This is the area where there's going to be motion. Of course, if the patient shifted a lot, the chest wall coverage is going to suffer, but this method isn't designed to account for that. It's designed to account for a difference in breathing or a difference in swelling during treatment. So when you look at that outer 1 cm ring, we see that they're actually much more comparable in what I would consider to be more realistic shifts or amount of swelling in positions 3 through 7, or perturbations 3 through 7. So my personal conclusions from this is I actually preferred the robust method. It was very straightforward to use. The plans just came out, in my opinion, better quality right out of the gate. There's really no opportunity for confusion about treating with or without bolus, since with the virtual bolus method, the plan printout has a bolus ROI on there. They'll say bolus somewhere, but they're not being treated with bolus, and that could just cause some confusion. But if you're in a bit of a time rush and you had time to actually sit down and dedicate to the plan rather than just hit optimize, walk away, and work on something else, the virtual bolus method may be the preferred technique. As I showed, you can get a round of optimizations in about a fifth of the time as the robust optimizer. All right.
So one of the things that we learned, and we've tried both ways. We did settle on the bolus way, and I'm not entirely sure why, but we never did a sim plan to sim plan comparison like you did. So that's good. But one of the things we found out was there are going to be times when you're going to question how much flash do you have, or the therapist is going to question how much flash do we have, because they're going to be down at the machine, they're going to take a cone beam CT, and they're going to notice that the breast that we're treating or the chest wall that we're treating has swollen to be outside of the area that we intended it to be, and they're going to need to be reassured that we've got the flash. And one way we found that we could do that is if we create a contour that is maybe like a cork structure around, and find out whether that gets dose, and then plot the 90% isodose line inside. So in the air around the breast or chest wall, place cork, calculate the 90% isodose line with the robustness. Now, if you do it with the fake bolus technique, you only have one number to worry about, right? There's only one 90% isodose line. But if you've got the robustness plans, there's multiple. So you could maybe take the one where you shift it by the worst case scenario, 1 centimeter, 1 centimeter, and then calculate it. But you come up with a contour, and you turn that contour, you come up with dose in the area around it, and you turn that into a contour, and that gives you a visible line downstairs on the machine that shows that if the breast is within that line, then we've got sufficient flash. Now, maybe you could get to the point where you don't need to prove it because you're using robustness and you're trusting the robustness, and you've looked at a bunch of previous patients and cone beam CTs for every patient, and you know that in no circumstances is it ever going to be worse than this distance. But there are going to be times that kind of challenge that, because we had a patient with, she had the breast expander that patients get when they have reconstructive surgery or prior to reconstructive surgery, and it stretches out the skin. That's what they're for. And she actually had a lot of swelling below that, and so what we were lining up to, what we had planned to, was a PTB of a certain volume, and we were running into issues where she had like swelled up a lot, and it was a lot different. And then, you know, even with 1 centimeter of robustness, that might not have been sufficient for her. So, but it's nice to be able to see at what point are we getting to the point where we're going to have to do something else. Robustness with 1 centimeter isn't going to cut it.
Hey, Jimmy, I have a question for you.
Yeah.
Just a quick methodology thing. When you were doing the virtual bolus plans, did you try re-optimizing after you switched off the virtual bolus while allowing it to only edit the MUs per control point, not the aperture shapes, or did you not try that?
No, I didn't try that.
It's probably a smart idea. It bricks the computer for several hours.
Yeah, I've done that in the past and I didn't like it. It'd be worth it to do it. I know it's like a nice finishing touch to try to get it to stay open more.
It kind of destroys the computer, but also the last plan that Cheyenne did, that was kind of what made it more acceptable, was allowing it to optimize a bit, because like you were saying, it was quite a bit of 105 once you switch off that virtual bolus structure.
Right.
I'd be interested to know how many places sweep this problem under the carpet and don't take Flash into account with IMRT and VMAP. But we might never know the answer to that. So
I'd be scared to know.
yeah.
No, I never admit it.
Yeah, I mean, what Jimmy did was a fair comparison, but there might be some additional tricks that we know you have to do with the bolus, the bolus plan, some final optimization, because we would probably not accept that one plan with the 10%. It's all over the place.
Yeah, right. Yeah, these could definitely have both been improved a lot. I just didn't want to.
Yeah, but I mean, but it proves that you have to fiddle more with the bolus plan to get it to be acceptable. That's for sure. All right. Any more questions? All right. Cool. We will. Thanks. We will move on to the some practice questions.